Hello friends, welcome to Medicator. After a long back, I am seeing you. Today we see in topic about Meconium aspiration syndrome. What is Meconium aspiration syndrome? How and all it cause difficulty for neonates? So this and all we will see in this video. So we'll go inside the video. So today content is introduction. What is Meconium? Pathophysiology of Meconium aspiration syndrome. Risk factor of Meconium aspiration syndrome. Signs and symptoms of Meconium aspiration syndrome. Diagnosis of Meconium aspiration syndrome. Treatment of Meconium aspiration syndrome. And the last complications of Meconium aspiration syndrome. So, first we will see what is Meconium aspiration syndrome introduction. Okay. So, Meconium aspiration syndrome is a serious and potential life-threatening conditions affecting newborns, and it occurs the baby inhaled the mixture of meconium and amniotic fluid into the lungs around the time of delivery. So this introduction relieves the into the nature of meconium, the circumstance leading the aspiration and implications of neonatal health. So what means meconium aspiration syndrome is one of the very serious and life-threatening conditions for newborns. So when a baby inhales the mixture of meconium and amniotic fluids, so it will be very difficult the lungs were done the time of delivery. So it will be leading a aspiration and it will be implications in neonatal healthcare. So here if you see means it is a normal uterus with amniotic fluids. So it's a normal anatomy. This is a meconium stained amniotic fluids. So this green color are all fully amniotic. Sorry, this green color fully will be a meconium. Okay. So when the child swallowed the meconium, it will be nothing will happen that time. When the baby is breathing that meconium, it will be go inside to the airway and it will be obstruction lung. And here you can see it's a meconium uterus. So when a baby breathe the meconium inside the airway, there will be obstruction in the airway. So you can see that the meconium plug it will be there. So now what we'll see what is meconium first. Okay, a meconium is a first poop. Baby's first poop is darker and thicker than typical poop and extremely sticky, and meconium built up inside the baby intestine and swallowed by amniotic fluids. So these fluids are surrounded and cushions them inside the uterus. Ideally, the baby passes a meconium shortly after birth. In some cases, a baby will pass a substance before they are born. So swallowing meconium wound is not harmful, but breathing it causes serious complications. So meconium is it's a first tool of babies. Okay, so it will be a darker and thicker and typically and extremely sticky. So this is a first stool of babies. Okay, so it will be inside the baby's intestine and it will be swallowing by the amniotic fluids. Okay, so what will happen if actually after birth only baby will pass this mechanism, but in some cases it will pass before born also. So before I said it's while you swallowing the baby swallowing the mechanism is nothing, it's not harmful, but when it the baby breathing it will be make a serious complications. So now we will see a pathophysiology of Meconium aspiration syndrome. So it's a pathology of Meconium aspiration syndrome is not completely understood for me, but I'll say an important process of 5 steps. Okay, meconium passage, aspirations, airway obstructions, inflammations, and surfactant inactivations. So first we'll see a meconium aspirations. So usually the fetal deflections will be rarely happens between 20 to 34 weeks of gestations. So it was noticed the utero-meconium passage is more common in late term and post-term babies after 37 weeks of gestations. Okay. So the several mechanisms will be hypothesized to play a role in process, including increased persistence and snitcher relaxations and changes in vagal and sympathetic tones and context of fetal distress and hypoxia. So here what they saying means It's a fetal deflection will be rarely will happen at 20 to 35 weeks of gestations. Okay. So if we notice the uteromeconium passage, it's more common in late term and post term babies after 37 weeks of gestations. Okay. So there will be several mechanisms will be happen that's hypothesized, and it will play a role in process of increased persistency and sphincter relaxations and changes in vagal and sympathetic tones in the context of fetal distance, and hypoxia will happen. Next, aspirations. So during the delivery process, what will happen is a fetal breathing usually leads to amniotic fluids and moving in and out of the lungs. When the amniotic fluid stains with meconium, the fetus is at the risk of aspirations. So this is especially true in hypoxia, and which can trigger the fetus to increase the gasping and leads to more amniotic fluid inhalations by fetal habit. So while the delivering process, you can see a fetal will breathe of amniotic fluids. In the lungs, it will be in and out. So that time the amniotic fluids with stained with meconium, no, it will be make a fetus to aspiration. Which expertly it will be make a hypoxia. When you trigger the fetus to increase the gasping, so that time when it leads to more amniotic fluid inhalations and feed by the fetal airway, it can happen. Airway obstruction. A meconium is a thick and fetal airway in a small in diameter. The presence of meconium in the airway it causes obstructions. So this mechanism is similar to foreign body aspirations. The meconium plug can cause a complete obstruction leading to lung collapse and as well as atelectasis. When a partial obstruction occurs, it can cause a ball valve effect with increased hair trapping. This increasing the risk of hair leak syndrome. So notably, it is a pneumothorax. The recent data suggests that the airway obstruction does not always happen in context of meconium stained with amniotic fluids, and it will be obstructions alone does not completely explain the meconium aspiration system. Here what they are saying is that meconium is it's a very thick substance, and if you see that fetal airway it will be a small diameter. So when the baby breathes that meconium, it will be obstruct in the airway. So it will be similar like a foreign body aspiration you can be take. So when the meconium belt is completely obstruct, but it lead to a lung collapse and distally as well as atelectasis will happen. If partially obstruction is there means that valvular effect will be increased and hair trapping, and it will be increasing the risk of hair leak syndrome. It's like a notably you can see as a pneumothorax. In recent data, it suggests the airway obstructions will be does not always happen in context of meconium stained amniotic fluids, and it will be obstructions alone. It does not completely explain with the meconium aspiration syndrome. Next, we will see about the inflammation. So in here, the inflammation will play a major role in the pathogenesis of meconium aspiration syndrome. So the material of constitution of meconium has been shown triggered inflammatory process that further contribute the development of respiratory distress in meconium aspiration syndrome. The airway inflammation results in the form of chemical pneumonitis, that is matrix metalloproteinase 8, interleukin 6, interleukin 8, interferon gamma, and tumor necrosis factors alpha have been described significantly with higher patients with meconium aspiration syndrome. Be obstruction in the airway. So that time it will be inflammation will be can happen. So it will be trigger the inflammatory process, and it contribute the development of respiratory distress in meconium aspiration syndrome. Inflammation will play a major role in the pathogens of meconium aspiration syndrome. So the material which constitutes a meconium, so it will what will do is trigger the inflammatory process, and it contributed to development of respiratory distress in meconium aspiration syndrome. So the hair inflammation will result in some chemical pneumonitis or matrix metalloproteinase 8, interleukin 6, interleukin 8, interferon gamma, and tumor necrosis factor alpha. So this syndrome describes significantly with higher in patient with the mechanism aspiration syndrome. So now we will see a surfactant inactivations. So the inflammation and hydrolysis can alter and inactivate the surfactant. This lead to increase the surface tension, poor compliances, and impair oxygenations. These further contributions or respiratory distress has been seen in meconium aspiration syndrome. So here what they say means inflammation and dialysis is the alters of and inactivate the surfactant. Okay, so it will be leads to increase the surface tension can be increased, and poor compliance and impaired oxidation will be a leading, it will be leads. Okay, this it further contributes the respiratory distress in Meconium aspiration syndrome. All these process leads to decrease in alveolar ventilation, causing increased ventilation perfusion mismatch. This is a main cause of hypoxemia in infants and with Meconium aspiration syndrome. A prolonged hypoxemia will trigger the pulmonary vascular constriction. It's turned the process of pulmonary vascular resistance. It's often accompanied right or left shunting, the mechanism triggered by persistent pulmonary hypertension in neonates. So here what they saying means the all process will decrease, the alveolar ventilation will decrease. So if alveolar ventilation will decrease, what will cause? It is an increase in ventricular perfusion mismatch will happen. And the main causes will be here means it's hypoxemia in infants with Meconium aspiration syndrome. So if prolonged hypoxemia means what will means it trigger the pulmonary vascular contractions and it increase the pulmonary vascular resistance and it accompanied the right or left shunting, and the mechanism will trigger that persistent pulmonary hypertension in neonates. Next we will see the what under risk factor. Now we will see risk factors of Meconium aspiration syndrome. So postpartum pregnancy. Next preeclampsia. So this means it will be increasing higher BP, higher blood pressures. Okay, in some people when they are in pregnancy, there will be higher BP will be happen. So that's name is preeclampsia. Next maternal diabetes, maternal hypertension, difficulty airway, fetal distress. Intrauterine hypoxemia is a condition which the fetus receives a decreased amount of oxygen while still in uterus. Next, we will see the signs and symptoms of Meconium aspiration syndrome. Each baby will be experiencing each Meconium aspiration syndrome differently, but there are some common signs will be there. That's why I mentioned here. Rapid and labored breathing, retraction or pulling in the chest wall, grunting the sounds with breathing, bluish skin colors called kynosis, low Acker score, a rating of baby color, heartbeat, reflex, muscle tone, and respiration just after birth. Next, limb body. Exposure of Meconium in amniotic fluids for a long time may cause a yellowish skins and nails. Next, we will see the diagnosis of Meconium aspiration syndrome. History and clinical presentation or context. A key in suspecting a diagnosis of Meconium aspiration syndrome. This is a very crucial as a yearly intervention and management can necessary for respiratory and cardiovascular support. Okay. So we will see the evaluations of Meconium aspiration syndrome. First we will take a chest X-ray. In chest X-ray findings will be a non-specific, but it includes a sticky densities bilaterally and a lateral findings of chest X-ray. It include hyperinflammations and flattening of diaphragms and atelectasis and pneumothorax also you can be seen in the chest X-ray. Next, arterial blood gas. So in ABG, it's a tool to access a respiratory failure and it helps to guide a management or intubation or mechanical ventilations. So in severe cases, ABG will show hypoxemic, hypercapnic and respiratory acidosis. And in pulse oximetry to access the oxygenations, but it also a degree of shunting. It's a pre-ductal and post-ductal differential you can see. Next, echocardiography. In ECG, it's an important tool to access for heart function and it helps to screen for signing a persistent pulmonary hypertension in units and it's a right ventricular dysfunction. So it helps to identify the cardiac anatomy and it evaluates any cardiac level of right and left shunting you can. Next, blood and tracheal culture you can. So evaluation of sepsis and pneumonia is a crucial in the context of neonatal distress. Often empiric antibiotics are started. So here what they say, it's a blood and tracheal culture we can see. So to evaluation of sepsis and pneumonia, it's very crucial to context and neonatal distress. So that time we will start empiric antibiotics will be started. Next we will see the treatment of Meconium aspiration syndrome. So in infants with Meconium strains of amniotic fluids, It should be a routine neonatal care while monitoring a signs and distress according to the general neonatal resuscitation guidelines. So, according to the 2015 guidelines of the American Heart Associations and the International Liaisons Committee on Resuscitations and American Academy of Pediatrics, is no longer to recommend a routine endotracheal sections for non-vigorous infants with Meconium stains or amniotic fluids. These infants with Meconium stains amniotic fluid should be observed by the signs of Meconium aspirations. What they say means, infants born with Meconium stains amniotic fluids, they should have a routine neonatal care and while monitoring a signs and distress in general neonatal resuscitation guidelines. So, according to 2015 guidelines of American Heart Association and the International Liaisons Committee on Resuscitations and American Academy of Pediatrics, so that's no longer recommend of routine endotracheal sections for non-vigorous infant with Meconium stained amniotic fluids. So the infants with Meconium stained amniotic fluids should be observed as signs of Meconium aspiration syndrome. So now we'll see that Meconium aspiration syndrome is a management is mainly supportive, but yearly identification and supportive can improve outcomes and decrease morbidity and mortality. So it requires an interprofessional team approach, including a obstetrician, midwife, neonatologist, respiratory therapist, nurse, pediatric pulmonologist, and pediatric cardiologist. So here what they say, Meconium syndrome is a management of mainly supportive, but yearly identification and supportive can improve the outcomes and decrease of morbidity and mortality. So it requires an interprofessional team approach. It's including a obstetrician, midwife, neonatologist, respiratory therapist, nurse, pediatric pulmonologist, and pediatric cardiologist. So now we will see oxygen therapy first. A supplement of oxygen is needed for a Meconium aspiration syndrome with a goal of oxygen saturations greater than 90% to prevent the tissue hypoxia and improve the oxygenation. So hypoxia is hypoxemia is an important trigger of pulmonary vasoconstrictions, which can increase a pulmonary vascular resistance and it's worse on the persistent pulmonary hypertension. So here what they say means supplemental oxygen is very important for Meconium aspiration syndrome to goal of oxygen saturation is greater than 90% want to be. So that time only we can prevent the hypoxia and tissue hypoxia and improve the oxygenation. And hypoxemia is very important to trigger pulmonary vasoconstrictions and it will increase the PVR and worsen the PPHN. Next, ventilator supports. This is indicated a refractory hypoxemia despite oxygen therapy and carbon dioxide retention and to increase the respiratory distress. It also has a role of respiratory support in PPHN and Ehrlich syndrome. There is no specific ventilation strategies. The oxygen, the oxygenation monitoring and serial ABG is to help to optimize the oxygenation and ventilations are the key. It's in severe cases of refractory hypoxemia, a patient may be require ECMO and cardiorespiratory support. So here what this means, to indicate the respiratory hypoxemia despite oxygen therapy and carbon dioxide retention and increase the respiratory distress means, and it's a role of respiratory support to in PPHN and Ehrlich syndrome. And there is no specific ventilation strategies for Meconium aspiration syndrome, and the oxygenation want to be monitoring and the ABG will be optimized oxygenation and ventilation scheme. So in severe cases with the refractory hypoxemia, a patient might require ECMO for cardiorespiratory support. Next, surfactant. The use of surfactant in Meconium aspiration syndrome is not a standard of care. However, as is discussed above, a surfactant's inactivation has a role of pathogenesis of Meconium aspiration syndrome. Therefore, the surfactant may helpful for some cases. So, what they say is the use of surfactant in Meconium aspiration syndrome is not standard care, but however we discussed above no. So, like the surfactant inactivation is a role of pathogenesis in Meconium aspiration syndrome. So, therefore, it will be helpful for some cases. Nitric oxide is an inhaled nitric oxide in pulmonary vasodilator that has a role in pulmonary hypertension and PPHN. So here what they say means the inhaled nitric oxide will be pulmonary vasodilator, so it will be role of pulmonary hypertension and PPHN. Next we will see the complications of Meconium aspiration syndrome. In short-term complications means PPHN and Ehrlich syndromes. In long-term complications means an infant with a Meconium aspiration syndrome can later develop reactive airway disease. And There are also a risk to neurodevelopment impairment. It could be also related to prolonged intubations and mechanical ventilations and prolonged oxygen will be needs. Okay, friends, thank you. Subscribe our channel. Somebody's are watching but not subscribing. Okay, if you do want to subscribe, it will be a motivation for me. And this PPT link will be I'll give in descriptions. Okay, share, subscribe our channel, share, like, and comment me. Okay, if any mistake is there means comment me. I will rectify that. Okay, share to your friends. Okay, and do subscribe for my channel. Okay, thank you, friends. Have a nice day. Bye.